Never been here before. It's a wonderful place, and thank you for your hospitality last night. Do any of you ever have a patient with pulmonary hypertension for non-cardiac surgery? Has that ever happened to you? Okay, a couple of you. I see them occasionally. Here's one. I'm going to tell you about this lady, this case. I'm not very proud of this case. I'll tell you what I learned. The patient is a 54-year-old woman. She was coming for an open wedge resection of a recurring metastasis of her left upper lobe. She'd previously had a thoracoscopic resection of a similar lesion a year before, and she had no problems with general anesthesia. However, she did have postoperative deep venous thromboses. 3 years ago, she had a colectomy, so apparently these are metastases from that. She has chronic obstructive pulmonary disease, hypertension, diabetes, she's on oral meds, she has obstructive sleep apnea, and she's morbidly obese with a BMI of 53. You probably don't have patients like this in India. No. But we see them where I work. Now, here's some of her laboratory investigations. She had an FEV1 of 65%. This is not bad. A DLCO of 78%. That's pretty good. Her ECG was normal. Her exercise tolerance, she couldn't climb a flight of stairs. So she had a transthoracic echo preoperatively, and her right ventricular systolic pressure is 32. She does not have pulmonary hypertension. At least I didn't think so. So what's your anesthetic management? Well, I'll tell you what mine was. Okay. First of all, since this was an open thoracotomy, I like to do thoracic epidurals for open thoracotomies. And even though she was very obese, I was very happy that we got a well-functioning thoracic epidural at T7 and 8. And with a test dose of local anesthetic, we mapped out a sensory level from T2 to T8. Very, very nice, no motor block. Then I induced her anesthetic. This was mine, some fentanyl, some propofol, some rocuronium. This is her systolic blood pressure in yellow at induction. Here's her heart rate in blue. Now, immediately after induction, she crashed. And I had to start giving vasopressors and inotropes and vasopressors and inotropes. And it went on and on and on for the next 3 hours. Vasopressors, inotropes, vasopressors, inotropes. Every time I used her thoracic epidural, her pressure crashed. Now, the surgery was finished in 3 hours. We woke her up. She was very comfortable on inotropes. We had to take her to the recovery room. Now, she can go to the floor. She didn't have an ICU bed. She was scheduled to go to her ward bed, but she can't go to the ward bed on inotropes. She can go with the epidural. I was stuck. So I decided to hold the epidural, try her with oral pain medication. She seemed reasonably good, and I sent her to the floor. We discontinued the epidural. That night, she went into respiratory failure and then was admitted to the ICU, and then she spent 4 weeks in the ICU, intubated and ventilated. I felt very bad about this case. And I knew that a year previously, she'd had an anesthetic. One of my colleagues had given her an anesthetic, no problem at all. And my colleague is a very good anesthetist, but I didn't know until then she was that much better than me. So I decided to look at her anesthetic. I hadn't actually looked at it, to be honest. This is my anesthetic. This is my colleague's anesthetic. Now, you're going to notice there's not very much difference here, except no thoracic epidural. She was having minimally invasive surgery, and we usually don't do thoracic epidurals for minimally invasive surgery. But look at the drugs. Some fentanyl, some propofol, some rocuronium, basically the same. A little bit of phenylephrine with induction, and that was it. She breezed through the operation a year ago. Now, I was still puzzled, so I decided to look at my colleague's preoperative assessment. Well, it's basically the same, except she has pulmonary hypertension with a right ventricular systolic pressure of 55. This is a year ago. Now, I actually looked at the echocardiography reports, which I confess I had not looked at. Okay? So, a year ago, she had a right ventricular systolic pressure of 55. This is pulmonary hypertension. The one I saw, 32, not pulmonary hypertension. And then, after she was in our intensive care unit for a week on a ventilator, they repeated the echo, RVSP 58. So what is this? Paroxysmal pulmonary hypertension? Anybody know? How do you get such differences in the right ventricular systolic pressure? It's simply an echo laboratory error. To measure the right ventricular systolic pressure, this is a transthoracic echo, right ventricle, left ventricle. Here's a big jet of tricuspid regurg. The sonographer puts a continuous wave Doppler through that jet and generates a pressure. They add on a factor for the central venous pressure, and you get your RVSP. But if this cursor is a little bit off, it's going to underread the RVSP. And that's merely what I got. I just got a lab error. Now, if I had it to do over again, if I'd known that she had an RVSP, would it have changed my management? Yes. Would it have changed your management? Well, you possibly don't see a lot of patients with pulmonary hypertension for non-cardiac surgery. So you might be tempted to go look up one of many review articles in our anesthesia literature on patients with pulmonary hypertension for non-cardiac surgery. And you'll start to read the introduction, and you'll find out that there are 5 major types of pulmonary hypertension. And under every type, there's multiple sub-diagnoses. And by the time you get to the end of the introduction, you'll get bored. And you'll think, maybe I'll go check my emails. I believe for us, anesthetists, there are 2 kinds of pulmonary hypertension. There's the pulmonary hypertension due to left heart disease, the poor left ventricle, mitral valve disease. And then there's the pulmonary hypertension due to lung disease. That's right heart disease, left heart disease. The 2, for us, in the operating room are very, very different animals. They're completely different, almost completely different. Why? Because one's left ventricle disease and the other's right ventricle disease. Now, this is work from Braunwald that you're probably all familiar with. Here we're looking at, this could be cardiac output. It's actually left ventricular stroke volume here, okay, on the vertical axis. And they're increasing the afterload by inflating a balloon in the ascending aorta in a dog. And as they increase the afterload, the left ventricle falls off a little bit. But it keeps working. Now they're going to do the same thing to the right ventricle. When you increase the afterload for the right ventricle, it reaches a certain point and it just dies. It just gives up. The right ventricle has a threshold. It can only deal with a certain increase in afterload. And that's why the 2 are so different for us. This is just a review of patients with pulmonary hypertension for non-cardiac surgery from a hospital in Taiwan. They just looked at everybody who had an echo, took out all those who had pulmonary hypertension, and looked at their outcomes and looked at what kind of surgery they had. But notice that 60% of the patients in this study, they're the right heart lung disease pulmonary hypertension. Those are the patients that you're most likely to see in your practice, not the left heart mitral valve disease patients. Now, when you read our review articles, these are some of the things that all the review articles are going to tell you. First of all, they'll say any anesthetic is good for induction. They'll say propofol's good. It's not that propofol's bad. What's bad is hypotension. When you've got the sick right heart, that right heart has to be perfused throughout the cardiac cycle, both systole and diastole. Hypotension, it can't be perfused during systole. Okay? The left heart's only perfused during diastole, so the left heart doesn't mind. The right heart fails in hypotension. Propofol causes hypotension, okay, if we're not careful. This is just a report of a patient who happened to have a pulmonary artery catheter in. We've got mean blood pressure in red, mean pulmonary artery pressure in yellow, CVP in blue. They induce anesthesia, the mean pressure falls, the PA pressure goes up. When the yellow line crosses the red line, that's bad, okay? And they immediately put in a transesophageal echo probe, and they saw a huge failing right heart. Hypotension is bad. Our number one job with these patients with right heart pulmonary hypertension is avoiding hypotension. The review articles tell you ketamine is bad. This is just not true. Ketamine has a bad reputation from the 60s when they used to use it for sedation in kids for congenital cardiac catheterizations. It's a bad sedative. They hypoventilated, the PA pressures go up. Those studies were repeated in the 80s. Kids with controlled ventilation, intubated, normal CO2s, PA pressures didn't go up. But ketamine still has a bad reputation. It's the drug that I use. You'll read that dobutamine is good. Dobutamine, levosimendan, all these drugs, the inodilators, they're great for left heart pulmonary hypertension. They're terrible for right heart pulmonary hypertension. They just cause tachycardia and hypotension, okay? So what do we use? What inotrope, what vasopressor do we use in right heart pulmonary hypertension? This is a study from Australia, recent study, okay? This is a human study, but it's a lab study. They took here systemic arteries and then exposed them to vasopressors. So this is looking at vasoconstriction here, maximal vasoconstriction. And the yellow line here is vasopressin, and this is a log dose concentration curve. They're just increasing doses of vasopressin, and vasopressin's causing systemic arterial constriction. That's what it does. It's a vasoconstrictor. And this is norepinephrine. Norepinephrine, same thing. Every drug they studied, every vasopressor, the same S-shaped curve in systemic arteries. But when they studied human pulmonary arteries, every systemic vasodilator had the same S-shaped curve. Here's norepinephrine, except one. See that yellow line? Vasopressin. In this laboratory study, vasopressin caused no pulmonary vasoconstriction. So it's the drug we use. Actually, my first line drug is still norepinephrine because I think it's a little more titratable, but 1B is vasopressin. The articles all tell you that nitric oxide is good. Our approach is, with these patients with the failing right heart from pulmonary hypertension, is systemic vasoconstriction and then inhaled pulmonary vasodilator. And nitric oxide is good. And where I work, we're a lung transplant center. We can get nitric oxide and connect it into our anesthetic circuit in the operating room in about 20 minutes. And it's a good selective pulmonary vasodilator. But most hospitals don't have nitric oxide. It's very, very expensive. But there's something that every hospital can have, and that's inhaled prostacyclin. Prostacyclin is a very inexpensive drug. It's used intravenously for patients with chronic pulmonary hypertension, but it can be nebulized. Here we are actually giving it to a patient during one lung ventilation through one side of a double lumen tube in this nebulizer. And this reference here gives you the recipe. And we dial it in. We start 50 nanograms kilogram a minute and titrate it up or down as needed, okay? It's basically as good as nitric oxide. Now, there is one caveat I have to warn you about, and that's it's dissolved in glycine, and glycine clogs up your heat and moisture exchange valve, okay? So you have to change your filter about every half an hour in the operating room. They don't use these valves in the intensive care unit, so that's not an issue in the intensive care. It's a wonderful alternative. It basically should be available in any hospital. Now, another thing that all the articles will tell you, transesophageal echocardiography is good for monitoring the right heart. And you can probably walk out the door and go into the next room, and there'll be some world expert telling you about how good transesophageal echo is for monitoring the right heart, okay? That's like the Bible, okay? That's the official story. I am a little bit skeptical. Here's a transgastric view of a healthy left ventricle. And up there on the shoulder of the left ventricle, that dancing donut, that's a healthy right ventricle. Okay? Now, if you look at this at the start of your case, and then you look again half an hour later and it's this. This, by the way, is a compressed left ventricle, and this is a huge dilated right ventricle in a transgastric view. Well, if it goes from this to this, that's bad. That right ventricle is failing. I mean, the surgeons can tell us that, okay? That's not rocket science. The problem is if you start with a sick right ventricle, and then you look 5 minutes later, and it looks like this. Has that ventricle gotten better or worse? I find it's very, very difficult on a minute-to-minute basis to make objective decisions based on TEE, right ventricular function. The left ventricle is very easy. The left ventricle is a geometric shape. It's a cone, you know, a cone. You slice through a cone, any 2 dimensions, you've got a good picture of the whole thing. But the right ventricle is like, it's like a mutant banana. You know, there's no way you can slice through that in any 2 planes and get a great idea of how the whole thing's doing. Now, every year I read about something, it's the magic answer for evaluating the right ventricle. There was TAPSE. There was fractional ejection change. Last year I read about RV free wall strain. That's a normal RV. And there's a sick RV. But after a year, I kind of got over my enthusiasm. These are offline measurements. I mean, I'm not saying echo is worthless. It's just on a minute-to-minute basis, it's not great. So what do we use? Well, this is really old technology, okay? PA catheter, okay? There's somebody with a pretty high PA pressure. The thing you have to realize is the PA pressure alone is not enough information. It's just a pressure, okay? If that pressure goes up, that's bad. We all agree on that. If that pressure comes down, maybe that's good. Maybe the right heart's getting better. Or maybe that's really, really bad. Maybe it's the right heart starting to fail. Imagine that you're standing by a very fast-flowing river, and there's a swimmer swimming upstream against the current. If that swimmer's holding his place in the river, he's okay. If he starts to go back downstream, that's bad. And that might be what happens when your PA pressure falls. You need more information than just the PA pressure. You need some measure of cardiac output. This is very old technology, mixed venous saturation and continuous cardiac indexes. There are many other ways, non-invasive ways of getting cardiac output. But you have to have some idea of cardiac output and PA pressures, and you have to use both to manage the failing right heart in these patients. Every article you read about anesthesia for the patient with pulmonary hypertension for non-cardiac surgery tells you how good epidurals are. Epidurals, spinals, regional anesthesia. And I admit it's good in most cases. All the articles are based on case series from obstetric anesthesia. Patients with primary pulmonary hypertension having lumbar epidurals for labor and delivery. And it's obviously, it's the right anesthetic for those patients. There are very, very few case reports of patients receiving thoracic epidurals with pulmonary hypertension. And I think it's because patients who have pulmonary hypertension are exquisitely dependent on their cardiac sympathetics, T2 to T4. If you block those cardiac sympathetics with your epidural, then you have a problem. Not a problem you can't deal with, but they need that inotropy. This is a study out of Belgium. This actually is a pig study, but they've since repeated it in humans. And what they're doing is they're comparing lumbar and thoracic epidurals in a model of pigs with pulmonary hypertension. They're looking at right ventricular output here on the vertical axis. The yellow bar is a control group. The red bar, pigs with lumbar epidurals. The green bar, pigs with thoracic epidurals. Here's the baseline, and here's after they dose up the epidural. And there's no change, okay? Right ventricular function is the same in all groups. But then they partially constrict the pulmonary arteries. And you see the control group and the patient with lumbar epidural, they mount some right ventricular response to the increased afterload. But the thoracic epidural group just makes no response. So if you do put an epidural in a patient like my patient, she's going to have to be on inotropes post-op. That's not a bad thing, because epidural's very, very good for that patient. But that's going to mean she's going to have a central line, and in my context, she's going to have to be in the intensive care unit post-op. Where is any of this written down? Really? Well, this is the only place I can recommend. Now, this is an article that most of you wouldn't read. It's an article on how to give an anesthetic with a patient with severe pulmonary hypertension for pulmonary endarterectomy. But it goes through exactly the same things I'm talking about. This group in San Diego, exactly the same practice that we have dealing with these patients with right heart disease and pulmonary hypertension due to lung disease. I'll just remind you that there is an oral form of nitric oxide, commonly called Viagra, that we can use to wean these patients. Since I've got a couple minutes, I'll tell you a really quick anecdote. One colleague of mine is a woman who's single and younger than me, and her passion in life is climbing mountains. And she's found that she's prone to high altitude pulmonary edema, so she takes Viagra prophylactically. So she was going climbing the highest mountain in South America. So she got a big store of Viagra, and she had it in her bathroom, all these boxes and boxes of Viagra. And her toilet developed a leak. So she called the plumber. So the plumber comes in, you know, attractive, young, middle-aged woman, leaky toilet, and a big pile of Viagra. So the plumber gave her a great big smile. So that's what I tell the pharmacist now. I tell the pharmacist that I'm going to climb a mountain. So in summary, when we talk about patients with pulmonary hypertension for non-cardiac surgery, for us as anesthetists, there are two kinds of pulmonary hypertension. There's the pulmonary hypertension due to lung disease. That's right heart pulmonary hypertension. And then there's the patients with left heart disease. Mitral valve, failing left ventricle. And those two respond very differently for us in the operating room. Thank you very much.
Any questions? Yeah. Mic, please.
Thank you very much, Peter. Really enjoyed your talk. In our hospital, to get prostaglandin E1 or prostacyclin is more difficult than we have Milrinone in all our drug cards. So do you have experience of using Milrinone as inhaled form, which Andrea Dinault is using routinely? And how does it compare with prostacyclin, prostaglandin?
Before we started using prostacyclin, we were using Milrinone. And the only thing about Milrinone is it was a bolus, and I never saw the recipe for a continuous infusion of Milrinone. It worked. Inhaled Milrinone works, okay? There's no doubt about that. We'd use it coming off pump in some of these patients, okay? Put it in our anesthetic circuit. That's the only thing about milrinone is I don't know the recipe to give it as a continuous infusion.
I have two questions. Number one, what is the dose of sildenafil in the postoperative pulmonary hypertension? Number two, what is the role of bosentan or ambrisentan in postop pulmonary hypertension?
So what's the dose of which?
Sildenafil, Viagra.
Sildenafil?
Yeah.
Oh, we just give the usual oral dose, okay, and we titrate as necessary, okay?
That's what, that
Yeah,
usual
we're
dose.
just giving it sublingual and titrating it as necessary, according to the PA pressures. And were you asking about the dose of prostacyclin?
I know there is controversies.
Was your other dose the dose of prostacyclin? Or your second question?
Second question is regarding the role of bosentan or ambrisentan.
Oh, bosentan?
Yeah.
Oh, well, those are chronic drugs, and the patients have to be left on them. That's the only thing.
Does it have a role on postoperative pulmonary hypertension?
I've never been involved in starting it for a patient in this context. We certainly get these patients who come to us on the drug, and then we just continue it.
Okay, thank you.
Hello, I'm Dr. Mutha. I wanted to ask you about laparoscopic surgery and pulmonary hypertension. Yeah, because there are two types of patients which don't have a pulmonary hypertension, and they, after laparoscopic surgery, 2 days later, they develop a pulmonary hypertension, or a patient with pulmonary hypertension going for a laparoscopic surgery. What are the problems with that?
Okay, so the thing about pulmonary hypertension and laparoscopic surgery is patients with pulmonary hypertension due to lung disease, their biggest risk in the postoperative period is respiratory failure. Anything we can do to decrease their risk of respiratory failure is the best we can do, our best management. Generally speaking, to do surgery minimally invasively, whether it's laparoscopic and thoracoscopic, is far better for the patient's outcome. So my approach in these patients is, after a discussion with the surgeon and the patient of the risks, then I usually try and go ahead and do whatever procedure it is in the patient with pulmonary hypertension, minimally invasively, with full monitoring, saying, we're going to try this, and if we can't do it, then you'll have to do it open. But basically, I'm almost always going to try to go ahead minimally invasively.
What will be your ventilation strategies during laparoscopic surgery in a patient of pulmonary hypertension? Because if there is a collapse of the lower lobe because of pneumo, there is increase in the pulmonary artery pressure.
Well, again, there we have these options that I mentioned. Okay, we're monitoring the pulmonary artery pressure. We have prostacyclin available. We have to try and avoid hypercarbia, okay, and acidosis. Both the acidosis and the hypercarbia contribute to the pulmonary hypertension. So we have to ventilate them in a fashion as best possible to eliminate, to avoid hypercarbia.
Thank you, sir.
Good afternoon, sir. I am Dr. Sandeep Patil. You have already told that pulmonary hypertension may be from left side or right, left ventricular disease or right ventricular disease. So in case of left ventricular disease, it may be first pulmonary venous hypertension. And from right side or lung as such, for example, lung problems or left-right shunts, it will be arterial hypertension. So do you think there is something different management for these cases from left side or right side, and which cases are easy to manage? Because in case of mitral stenosis, there is some pulmonary hypertension that is easy to manage, or in case of VSD, patient having left to right shunt, that those patients having pulmonary hypertension. So which kind of pulmonary hypertension will be easy to manage and for non-cardiac surgeries?
So you're asking, would I rather deal with a patient with pulmonary hypertension from severe left heart disease or severe right heart disease? That's like asking me, would I rather be eaten by a lion or a tiger? You can't generalize. At the extremes, they're both very difficult. But the big difference is the inodilators are very, very good drugs for the left heart disease. So you start with those and then you add your other drugs, okay? But they're very bad for right heart disease, so you start with the other drugs first.
Okay. Thank you.
Hello, good morning, this is Dr. Shraddha Nair. So what would you recommend for a patient with pulmonary hypertension, like diagnosed just in the preoperative period during a pre-anesthesia checkup, scheduled for an orthopedic surgery? Because then for an orthopedic surgery, like a lower limb surgery, he'll be given a subarachnoid block. So do you recommend starting a inodilator in such a patient, or if he's already on an inodilator, will you recommend in continuing the inodilator?
I'm sorry, I couldn't hear the very end of your question. So we've got a patient for orthopedic surgery and we're going to do it with a regional.
Right.
And then what I recommend.
Yes, do you recommend if the patient is just diagnosed during the pre-anesthesia checkup, do you recommend in starting the inodilator, because then there will be precipitous hypertension with the subarachnoid block and the dilator that he is on. So do you recommend starting it preoperatively, and if he is already a diagnosed patient, do you recommend in continuing it during the perioperative period?
Well, so first of all, if it's pulmonary hypertension due to lung disease, I'm not going to be using an inodilator. I'm going to be using a vasoconstrictor.
Okay.
And would I start it at the beginning of the case? Yes.
But then do you expect exaggerated hypotension because of the subarachnoid block that he'll be having?
Well, I think you all have ways of managing a subarachnoid block to decrease the hemodynamic effects. Okay, and that's what I would do with your patient positioning, limiting your block, and so whatever you can do to decrease that hemodynamic effect. Anticipate it. I don't think volume loading is usually very efficient. So I go with vasopressors, and I would start the vasopressor right away.
Okay, so you recommend in continuing the pulmonary vasodilators.
And what about the pulmonary vasodilators?
You recommend in continuing them during the perioperative period also?
Oh, yes. Yeah, if they come to you on pulmonary vasodilators, you have to continue them. Absolutely.
Okay. Okay.
Absolutely. Yes.
Okay. Thank you.